So we are here and we're just going to present the case to you to start with.
Can I have the slides?
We'd like to see the slides for the case, please.
So this is a 63-year-old patient who 5 years ago has had a colonoscopy with removal of a small tubular adenoma. Today we do the surveillance colonoscopy. On the next slide we have some quality parameters, and in this case as well we have a multiple choice question. On the next slide. So for you, what is the optimal position of the patient for inspection of the splenic flexure? You have the options right there.
So here with Christophe, and we're just going to start the intubation. I want some discussion from the moderators, from John and Roland. If you're watching this, if you can see the endoscopic image, about how he's doing. And so we're just going to let him start. So he's right here on the anal verge, and then I'm going to let him progress and discuss the findings as we go, and I'll discuss the scope guide image, etc. We'll do about 4 minutes of this, and then we're going to go to the beautiful video already provided to us from Cheltenham. So Christophe, take it away.
All right, so we start in the rectum here, and take the first turn. And we immediately saw we had to take a good look first, but this gentleman has some diverticula here, and we think this is going to expand the lumen a bit, insufflating some carbon dioxide with some mucosal prolapse.
So you've got a cap on the scope, Christophe.
Yeah.
That makes it wider. I mean, the lumen looks quite narrowed. What are you thinking about the safest way to proceed?
We could use some water.
Yeah. What do you think, John and Roland?
I'll hand this to Roland. Go on, Roland.
Well, we like using water on the way in, and we like to use minimal sedation as well. So providing the is good, which it does look very good.
Yeah, the gentleman had 2.5 milligrams of midazolam to start and 25 micrograms of pitidine.
So important to note the patient's under conscious sedation. Yeah.
Can I just add, David, that if you're still in the rectum, putting water in the rectum often isn't well retained. So intubation of the rectum is often better done with air. And if you're going to switch to using water, it's sometimes best to get the instrument beyond the recto-sigmoid junction, so you can infuse the water and fill the sigmoid colon, but leave the rectum relatively dry, just for compliance with the patient, really.
Yeah, I think it's important. And of course, there's something else we should probably be thinking about now, Christophe, or something else you're thinking about?
Well, I think we should biopsy this lesion.
Well,
not the lesion.
That for me is a typical appearance of mucosal prolapse. Around it, you can see multiple diverticuli. Would you agree, John and Roland?
Yeah, it's a bit difficult. Our image is quite small, David, so...
okay, your image is too small. Okay. So from the endoscopic image, we can see that. But it's something in terms of progression, Christophe.
So we start here in the left lateral.
Okay.
I think for the sigmoid, that's a good position.
Yeah. But I think turning the patient now, I think maybe John and Roland would agree, would be something to consider to enhance progression. So let's do that.
Okay. To the back.
Other patient.
So do you agree with that, Christophe? Or were you quite happy with them in the left lateral?
Yeah, maybe to just... Normally I start in the left lateral, and then maybe when I'm past the sigmoid, turn to the supine position.
They have to have buy-in, and what the tracking devices do is get buy-in to what you're trying to teach them.
I noticed it, John. I mean, I was watching Christophe do the colonoscopy before, and you said, don't use water in the rectum. I was like, how does he know that we're still in the rectum? And of course, John is just looking at the scope guide, and that's how he trains, that's how he knows what's going to happen. You watched yesterday's beautiful insertion video, and that's how he's able to, because he's a master of the imager, the master of the front and back view as well, and that's how he knows.
So, written by Dr. Anderson recently, these are the steps involved in a safe and effective therapeutic practice way of progressing. So first action needed to be handled is, of course, to reach the area needing therapy. So it's based on intubation skills. The second point is to recognize the lesion, of course, and to know about which lesion need a therapy and which kind of therapy is needed. The third one is about decision-making and judgment. And the fourth and fifth one are therapeutic skills, like the delivery of the therapy and managing complications.